Today we are going to discuss aortic regurgitation. Now, what is aortic regurgitation? Aortic regurgitation is actually a dysfunction in the aortic valve. The aortic valve is placed between the left ventricle and the ascending aorta. When this valve dysfunctions, the blood starts coming back from the aorta into the ventricle. So this is aortic regurgitation. Some people call it aortic insufficiency as well, but the appropriate term is aortic regurgitation. Now, the aortic regurgitation can present as an acute condition or it can present as chronic syndrome. In acute, which is less common than the chronic, patient may have because of the infective endocarditis. When there are vegetation on the aortic valve, some of these vegetation may cause destruction of the valve leaflets or the chordiotendae which are holding the valve leaflets. So that may result in acute aortic regurgitation. Then prosthetic valve dysfunction, aortic dissection and trauma can result in acute aortic regurgitation. Similarly, systemic hypertension sometimes can result in acute aortic regurgitation, but most of the cases of aortic regurgitation fall into the category of chronic aortic regurgitation. Now, the chronic aortic regurgitation goes on for a very long period before it clinically presents. Now, what happens? We can divide the chronic aortic regurgitation into different categories. For example, the most important, most common category is the patient suffering from aortic regurgitation as a consequence of rheumatic carditis, that is rheumatic heart disease. So the patient may have associated aortic stenosis as well. There may be mitral valve involvement. The patient has aortic regurgitation as well. And then there may be aortic regurgitation in the congenital bicuspid aortic valve. Similarly, infective endocarditis, which is of low-grade intensity, can result in chronic aortic regurgitation. Then poorly controlled chronic hypertension can result in chronic aortic regurgitation. And then there is a list of conditions which can cause dilatation of the aortic root. When this aortic root is dilated, the valve, they cannot coapt, they not come into close proximity to each other so that the aortic orifice can be closed. So that can result in aortic regurgitation. For example, Marfan syndrome, the cystic medial necrosis, osteogenesis imperfecta, Ehlers-Danlos syndrome, and tertiary syphilis. All these conditions can result in the dilatation and sometimes even the aneurysm of the ascending aorta. So that can result in aortic regurgitation. Then certain inflammatory conditions are associated with aortic regurgitation, notably the ankylosing spondylitis, the rheumatoid arthritis, the systemic lupus erythematosus, the Behçet syndrome, the giant cell arthritis, and the Takayasu's arthritis. So these can be related with aortic regurgitation, and some of the anorexic drugs like fenfluramine and dexfenfluramine that can result in aortic regurgitation as well. So we have got different conditions which can cause chronic aortic regurgitation, and you may have acute aortic regurgitation. The acute aortic regurgitation generally presents very dramatically and acutely, while this presents after a very long latent period of sometime maybe it is 10 years, the lesions are going on and the patient does not present clinically. So depending upon the different type of condition, the chronic aortic regurgitation can present after a variable period of time after the regurgitation was actually started. Now, what happens when there is chronic aortic regurgitation? There is elevated left ventricular end diastolic volume and end diastolic pressure. So you can see what happens. During systole, the blood is ejected from the left ventricle into the ascending aorta. And during diastole, the blood tends to come back, but the aortic valve prevents this from happening. So during diastole, when the valve is not functioning, the blood starts coming back into the left ventricle. Now, during diastole, the left ventricle is receiving blood both from the left atrium and from the aorta. So that means during diastole, the volume in the left ventricle is high. When there is a high volume, the diameter of the left ventricle starts increasing. And according to the Frank-Starling law, when there is increase in the diameter of the heart, it contracts more forcefully. That means the intraventricular pressure will also start rising. So as a consequence of this, we have elevated left ventricular end diastolic volume and there is elevated left ventricular pressures as well. Now, when there is increase in end diastolic volume, there is increased LV preload. So there is a high LV preload that results in increased force of contraction. Now this ultimately after a long time results in left ventricular dilatation and left ventricular hypertrophy. The left ventricle starts increasing in diameter and the muscle also starts hypertrophying. As a consequence, the patient have increased stroke volume and increased ejection fraction. That is, when they contract, the left ventricle ejects more blood. So the stroke volume increases. Similarly, the ejection fraction. Ejection fraction is the amount of blood which is ejected with each systole as a fraction of the diastolic volume. So not only stroke volume increases, ejection fraction increases. So this keeps on maintaining the perfusion of the peripheral organs, and when this situation continues for a very long time, there is further rise in left ventricular end diastolic volume and end diastolic pressure that results in left ventricular failure and ultimately myocardial ischemia, and the patient starts presenting clinically with the features of aortic regurgitation. So this is all what happens in chronic aortic regurgitation. That is, the blood regurgitates into the left ventricle. The blood from the left atrium is also coming in the left ventricle. The left ventricle starts dilating and having increase in left ventricular diastolic volume, and there is increase in left ventricular pressures. So the consequence is left ventricle starts hypertrophying, there is dilatation, there is increase in stroke volume, there is increase in ejection fraction. So that maintains tissue perfusion. And ultimately, if this situation continues, the left ventricle starts failing and the patient starts having symptoms of aortic regurgitation. So this is what happens in chronic aortic regurgitation. And now this is what happens in acute aortic regurgitation. There is a sudden rise because there is a sudden leakage of blood into the ventricle. So there is a sudden increase in left ventricular and diastolic pressures. The pressures are very high. They cause an increase in pulmonary venous pressure because when the pressure in the left ventricle is high, this pressure is transmitted into the left atrium. And from the left atrium, since there is no well between the left atrium and the pulmonary veins, this pressure is transmitted backward into the lung and the pulmonary capillary pressure starts rising. So there is an acute aortic regurgitation, the pressures are transmitted backwards into the pulmonary capillary and the patient starts developing pulmonary edema as the pressure in the pulmonary capillary starts rising. So the patient has dyspnea and may present in emergency with acute pulmonary edema. So this is slightly different from chronic aortic regurgitation where the process is slow and takes a very long time in decompensating and failing the left heart, but in aortic regurgitation it can be sudden in cases of acute conditions. Now, what are the symptoms in chronic aortic regurgitation? The patient may have palpitations because the force of contraction is increased. So you have palpitation when there is increased force of contraction or increased rate of contraction. Patient may have head pounding because there is a high cardiac output state. Patient has excess diaphoresis because the metabolism is high in these patients. Patient may complain of exertional dyspnea. There may be orthopnea. There may be sometimes paroxysmal nocturnal dyspnea. The patient may present all the features of congestive cardiac failure. In patients, if the end diastolic pressure compromises the coronary filling, the patient they also start having features of angina. So the patient may present with chest pain as well. They don't only have shortness of breath, they may have chest pain as well. So any patients who present with features of heart failure and angina, one should evaluate for the presence of aortic valve disease. Now, the patients, as I mentioned, they remain asymptomatic for a very long time in chronic aortic regurgitation. It may be a period of 10 to 15 years after the development of the lesion when the patient starts becoming symptomatic. Now, the peripheral examination in cases of chronic aortic regurgitation. You see, most characteristic feature is the pulse, which is called Corrigan's pulse, water hammer pulse, or a collapsing pulse. So these are different names for this. When you examine, you've got a very bounding pulses, and one way is that you hold this pulse in your palm and then suddenly lift the arm upwards, and you see the pulse starts striking the palm. So this is called Corrigan's or water hammer or collapsing pulse. Now what we see in this pulse, there is a rapid upstroke and is a rapid downstroke. When we compare this with a normal pulse, which has a slow upstroke and a downstroke, and this is the pulse of aortic stenosis. When there is a slow rise, there is a plateau and there is a slow decline. But what happens in aortic regurgitation? That there is a sudden rise, there is a peak, and there is a sudden fall. So the patient has this sort of a pulse in aortic regurgitation. There are different peripheral signs which can be seen in patients who got aortic regurgitation. For example, Trobbe's sign is called piston shot. When you put your stethoscope on the femoral artery, you hear piston shot with each heartbeat. Then you got Muller sign. Muller sign is when you open the patient's mouth and you see the uvula. The uvula beats with every pulse. So this is called Muller sign. Then patient may have Drosius sign or Drosius murmur. This is a diastolic murmur which can be heard over the femoral artery. So this is characteristic of aortic regurgitation. Although this is not seen in a large number of patients, when this diastolic Drosius murmur is present at the femoral artery, this is a very strong suggestive sign that the patient has aortic regurgitation. Then you got Quinicke's sign, that is capillary pulsations. When you press the nail slightly, you can see a pink border of the capillaries, and you can see this pink border moving like this. So this is called Quinicke's signs. Then you got Demusset sign. Demusset sign is that with every heartbeat, the head pounds like this. Patient may have Hill sign. Hill sign is that you take the blood pressure in the brachial and the popliteal arteries. The popliteal arteries, they show a blood pressure of 40 millimeter or more in systole as compared to the brachial arteries. So this is called Hill sign. And then you've got Becker sign, that when you do the fundoscopy, you can see the retinal vessels pulsating, retinal arteries pulsating. So this is called Becker sign. So you can see all these different signs in patients who got chronic aortic regurgitation. Then we come to the precordium. What happens to the precordium? We localize the apex. The apex might be shifted downward and outward because the heart is dilated. So the apex may not be present in the normal place, that is in the fifth intercostal space around the mid clavicular line. It may be shifted slightly outward, and if the heart has started failing, it may also be shifted downward as well. So you may have a ill-sustained heaving apex beat which may be displaced laterally, or it may be displaced downward and laterally. You can hear heart sound. The first heart sound is generally soft. The second heart sound sometimes may not be audible. But if the patient has aortic root disease as a cause of aortic regurgitation, in these patients the second heart sound, that is the aortic component, is normal, and sometimes this may be loud as well. When the patient has failing heart, you may hear an S3 gallop due to increased left ventricular end diastolic volume and impaired LV function. So you can hear heart sound like this. The S1 may be soft, S2 may be absent, and there may be A2, which may be accentuated sometimes in patients who've got aortic root disease. There may be third heart sound because of the failing heart. You may be able to auscultate that. And then we come to the precordium. We hear the characteristic murmur of the aortic regurgitation. You see, this is called early diastolic murmur, or EDM. The murmur in the aortic regurgitation is early diastolic. It is a high-pitched blowing decrescendo murmur. This is heard best in the left third intercostal space when the patient is sitting, leaning forward, and the respiration is held in forced expiration. So the patient leans forward, expires, and holds the respiration in expiration phase. You can hear this murmur well. Then patients who got aortic root disorders, the murmur is heard on the right parasternal area, the right second intercostal space. If you have a cooing or musical murmur, that may be because of eversion of or perforation of the aortic cusps. The longer the duration of murmur, the severer is the aortic regurgitation, and the aortic regurgitation murmur becomes short in patients who've got cardiac failure. So now, in addition to the early diastolic murmur, patients also have different type of flow murmurs. Patient may have ejection systolic murmur. Since during aortic regurgitation, large amount of blood comes to the left ventricle, and when the left ventricle contracts, a large amount of blood flows across the aortic valve. So that may result in an ejection murmur, which is a flow murmur. It may sometimes be radiating to the carotids. And then patient may have Austin Flint murmur. What is an Austin Flint murmur? When there is aortic regurgitation, the regurgitant jet sometimes lands on the anterior mitral leaflets. So this causes closing of the mitral leaflets. And when the blood is coming from the left atrium into the left ventricle during a diastolic phase, this narrowing may produce a mid-diastolic murmur, which is soft, low-pitched, rumbling mid-diastolic murmur. It's called Austin-Flint murmur. This has to be differentiated from the mitral stenosis, which can particularly be present in patients who've got rheumatic heart disease. So this is caused by the diastolic displacement of the anterior mitral leaflet by the regurgitant jets. So now what we see is in aortic regurgitation, so this is the systolic phase and this is the diastolic phase. During diastole, since there is a high pressure in the aorta and the ventricular pressure falls, you see the left ventricular pressures, they rise like that and then they fall, while the aortic pressure is like this. You see, at this phase, the left ventricular pressure starts falling, but the aortic pressure is still high. So that results in blood moving from the aorta into the ventricle. So we see the early diastolic murmur in the early phases of diastole because large amount of blood regurgitates at this time. And when this blood is moving inward into the left ventricle, the jet may sometimes cause displacement of the anterior mitral leaflet that may result in mid-diastolic murmur. So this may be a murmur which is confused with murmur of mitral stenosis. And when this phase goes on, the systole comes in, there is a large amount of blood which is present in the left ventricle which is forced upward that can result in a systolic murmur. So these are the different type of murmurs patient can have during systole and during diastole in patients who got aortic regurgitation. You see, all the auscultatory events are intensified by the hand grip. As the hand grip maneuver is applied, there is increase in peripheral vascular resistance. Since there is increase in the peripheral vascular resistance, this causes more regurgitation of the blood. So all these phenomena, they are increased in patients if they are asked to apply the sustained hand grip maneuver. Then acute aortic regurgitation. Acute aortic regurgitation, as I said, presents with sudden onset of heart failure. The patient may have tachycardia. There may be pulsus alternans because of the heart failure. Patient may have peripheral vasoconstriction as a result of a sudden sympathetic discharge. Patient may present with cyanosis. There may be pulmonary edema, and the left ventricular apex may be normal as opposed to the apex seen in chronic aortic regurgitation when it is displaced and ill-sustained heaving. The early diastolic murmur, the Austin-Flint murmur may be present in these patients, but they are difficult to appreciate in these patients. Then what testing is required? We go for routine testing like CBC, coagulation profile, the VDRL, the autoimmune profile, the electrolytes, the lactate dehydrogenase. So we go for these routine testing, and then we can go for some investigations like imaging. For example, we go for a chest X-ray that may show us cardiac dilatation, there may be dilatation of the aorta, and there may be pulmonary congestion. The ECG may show there may be left ventricular hypertrophy, there may be left axis deviation, there may be left atrial enlargement. The features of volume overload in the ECG as well may be seen. Then on imaging, we can see on echo there is dilated left ventricle, there is hyperdynamic left ventricle, there is fluttering of the anterior mitral leaflet. Doppler echocardiography may quantitate the amount of regurgitating blood. Similarly, on angiography, you can see the dilated LV, the hyperdynamic LV, and at the same time, you can go for the coronary anatomy. If the patient is presenting with features of angina, we can do an angiography. This is an indication to do an angiography where we can see the coronary vasculature as well, if there is a concomitant coronary artery disease present or not. And the cardiac CT and MRI are the investigations which are still under investigations, and they are not really standardized as yet. Then how do you assess the severity of the aortic regurgitation? In the peripheral sign, you see increased peripheral sign we seen. On precordium, we see if the patient has third heart sound, it means the heart is failing. If there is left ventricular hypertrophy and dilatation, that means the heart is failing. The Austin Flint murmur tells us about the severity of the lesion, and similarly the duration of murmur. The longer the murmur, the more severe is the lesion. So this is we go for clinical assessment. The differential diagnosis includes thyrotoxicosis, severe anemia, pregnancy, and wet beriberi. They all produce high output cardiac failure, and they have bounding pulses. Similarly, AV fistulas, particularly the patent ductus arteriosus or AV malformations in the periphery, they can present with high bounding pulses. Sympathetic overdrive, patient has tachycardia, patient is sweating, and patient may have palpitations, so that has to be differentiated. Patients sometimes may present with chest pain, so the acute coronary syndrome should be considered. Patients may present with heart failure. Look for the features of infective endocarditis. The murmur has to be differentiated from the murmur of MR, the MS, the pulmonary regurgitation, and tricuspid stenosis. So all these are the differential diagnosis of aortic regurgitation. Now the management is medical and surgical. Actually, the management is surgical. Medical management is not the treatment for aortic regurgitation. It is just symptomatic treatment. What we do is we can use vasodilator drugs like ACE inhibitors or ARBs. We can use diuretics. We can go for infective endocarditis prophylaxis, and we go for the treatment of underlying cause. For example, if there is tertiary syphilis, we can treat it, or if there is a disease causing aortic root dilatation, we can go for the replacement of that segment of the aorta. So we go for an treatment of the underlying cause. Surgical treatment is aortic valve replacement. It may be a mechanical valve or it may be a bioprosthetic valve. And the replacement can both be open or it can be catheter. Open, especially if the patient has coronary artery disease, or if you want to do another cardiac procedure, then it's better we go for an open cardiac surgery. Otherwise, if it is pure aortic regurgitation, we can go for a transcatheter placement of the aortic valve as well. Then patients who present with aortic regurgitation because of aortic root dilatation, we can go for aortic root replacement, for example, in syphilis, in Marfan syndrome, or in dissecting the aneurysm of the aorta. Patients who present with acute aortic regurgitation, we can go for an inotropic support, we can use vasodilators, we can use cardiac glycosides for the control of heart rate. So these drugs can be used for those patients. Then in home, we go for aortic valve replacement. If the patient has symptoms of congestive cardiac failure, if the patient has declining exercise tolerance on ETD, we do an ETD at intervals and we find the patient cannot tolerate exercise and the exercise capacity is decreasing. If the patient has features of angina, these patients may require aortic valve replacement. And then we can have echo criteria. For example, if there is presence of LV dysfunction, that is the ejection fraction is 50% or less, these patients may require aortic valve replacement because the normal perfusion is maintained by a very high ejection fraction. If the ejection fraction even is normal in these patients, it is generally said that the LV dysfunction has started. Progressive LV dilatation on decline in EF on serial echo studies. So serial echo studies show that either the LV function is declining or the LV is dilating. We can consider aortic valve replacement. And then severe dilatation, for example, left ventricular diastolic dimension, that during the diastole, the left ventricular dimension is more than 65 millimeters, or during systole, the dimension is more than 50 millimeter, or the aortic root is more than 50 millimeters. These patients, they require aortic valve replacement. Severe AR when undergoing cardiac surgery, if the patient is going for cardiac surgery for another reason, for example, ischemic heart disease, and the patient has severe AR, the aortic valve replacement can be done at the same time. Then vasodilator, where to use vasodilator, when to use and when not to use. The general indications are, if the patient has severe chronic symptomatic aortic regurgitation and patient is not a candidate for surgery. So if we are not planning a surgery but the patient has symptomatic chronic aortic regurgitation, we can go for chronic vasodilator treatment. Patients who are asymptomatic, they have severe AR with LV dilatation and normal ejection fraction. So if their ejection fraction is still maintained although the LV is dilated, these patients can be put on vasodilators. But the patients who got asymptomatic with normal cardiac size and normal ejection fraction, where in this patient we do not use vasodilators. So if the patient is asymptomatic, patient has severe AR and there is LV dilatation but the EF is still maintained, in these patients we can put on vasodilators. But if the patient are asymptomatic but they have a normal cardiac size and normal ejection fraction, in these patients vasodilators are not indicated. So if a patient has no symptoms but the LV is dilated despite the ejection fraction is maintained, patient should be put on vasodilators. But if the cardiac size is normal, don't put on vasodilators. Similarly, asymptomatic or symptomatic patients who are candidates for surgery. So if you are planning for surgery, they are symptomatic or they're not symptomatic, we can go for, we should not go for long-term vasodilator treatment. So these are different indications and contraindications for using vasodilators in patients who got aortic regurgitation. So this is about aortic regurgitation. Next time we'll discuss another subject of the cardiovascular system. Till then, goodbye.